Hello, welcome back to another digital surgical pathology slide sign out. I'm Dr. Louis Hassel, and our services are facilitated by the Digital Anatomic Pathology Academy, a joint venture of the Digital Pathology Association and Path Presenter. My time is also sponsored by the University of Oklahoma Health Sciences Center. Our topic today takes us back into the realm of ovarian pathology. The history is a little bit longer and more complex than typically. This is a 46-year-old woman who developed some abnormal bleeding, vaginal bleeding, and was found to have enlarged ovaries. Of note, she is 6 years since she'd had a bilateral mastectomy for stage 2 breast cancer, following which she had received 5 years of oral treatment with tamoxifen. And of course, tamoxifen is known to cause some menstrual problems and potentially endometrial cancer, so she reported to her gynecologist very promptly when she developed that symptom, and it was then that it was noted that her ovaries were enlarged. Well, they were removed because of that concern, and found, here we can see a quite nicely enlarged ovary, but it's really not terribly recognizable as ovarian tissue. It's got a fibrous background, some vessels, some bluish areas, but it doesn't look like what one might expect in the setting of potentially a BRCA2 mutation carrier who might be more likely to have breast cancer and then a secondary ovarian cancer of the serous type. No, this looks to be a more diffuse process with some sieve-like areas and pale blue and variable areas. We do see a little evidence of surface involvement here as well. We'll magnify this up a little bit more and to take a higher power view of what's going on here, and we see a small scattered gland pattern coursing through this desmoplastic or fibrotic stroma with some more cellular areas with probably small glands here. And we also see something a little bit unusual. We see some small calcifications here, another over here, resembling psammoma bodies. And of course, many ovarian tumors will make psammoma bodies, but also some breast cancers will as well. So we'll take a little closer look here at this cellular area. And here we see the nuclear features are fairly small and uniform. They're fairly uniformly spaced in the glandular structures. There's bridging and cross streaming of cells. We see some very large and atypical nuclei with some cleared out cytoplasm. We see secretions in the lumen, variable shapes of some of the nuclei. And looking around a little bit more, we see that some cells have these sharp lumina, as seen here and here, associated with these microcalcifications. And these calcifications do not, at this point, look particularly like psammoma bodies. They look just like coarse calcification. Also, we can note that some of these glandular structures have a smooth lumen, while in others we see little snouting processes on the surface of the lumen, suggesting that sort of apical snout appearance. We do not see evidence of cilia in any of these cells. There are no terminal bars to be evident here, even though the brush border may be a little bit accentuated. So going back to a little lower power, we'll just see if there's any other areas of note here. Pretty uniform, diffuse involvement with some sclerosis here. Here we can see, as we look towards the surface over here, we can see that indeed the surface looks to be involved, or at least the immediate subsurface area. And sometimes that can be helpful in metastases. You'll get both nodular parenchymal involvement as well as surface involvement. Here again, we see the variable small gland pattern and then more consolidated appearance with this bluish secretion within the lumina. So based on the morphology, this does not resemble any of the typical ovarian primary tumors, and we would want to be thinking about metastasis. Of course, breast cancer comes first to mind because of the patient's history, but this mucinous glandular pattern could also be seen in several other metastatic lesions, such as metastatic tumors from the pancreas, stomach. We will look a little bit further and think what stains might be useful to differentiate these. Certainly, there are several stains that could be useful in differentiating breast from intestinal from ovarian. GATA3 comes to mind as a possibility. CDX2, of course, would stain many colonic and enteric tumors. And we might also look at things like PAX8 or WT1, CA125 as potential markers. And those would usually give us our answer. GCDFP15 is also a consideration. Metastatic carcinoma in general to the ovary frequently presents in younger patients, and it may provoke some stromal luteinization and thus hormonal effects interfering with normal hormonal cycling. It's commonly bilateral and may in fact result in large ovaries that would probably dwarf the size of many of the primary tumors. So in this case, the metastasis may be much larger, and that can be sometimes clinically deceiving. They do have the ability to mimic many of the primary tumors. We saw in our case the presence of calcifications potentially mimicking serous tumors. And this one had some mucinous appearance that could mimic mucinous tumors as well. Intestinal or appendiceal mucinous tumors are particularly prone to mimic ovarian mucinous tumors. If we see vessel involvement or the combination of surface and a nodular or desmoplastic growth, such as we had today, that would be a vote in favor of metastasis. And not uncommonly, the primary tumor may not be discovered until much later, sometimes years later or even at autopsy. Looking specifically at breast carcinoma, most commonly we see ductal carcinoma, as today's case illustrates. But in fact, lobular carcinomas are more prone to metastasize to the ovary. And they, again, may mimic surface epithelial tumors. Carcinoid tumor comes to mind, as well as possibly granulosa cell tumor, as these tumors may occasionally invade primary follicles and displace the normal theca cells. We've mentioned the immunoperoxidase that may be helpful in this specific instance. GCDFP15 and GATA3 would be positive in breast cancer. WT1, PAX8, CA125 would be positive in most primary ovarian tumors. And given this association with BRCA, we do have to think about both the possibility of primary ovarian carcinoma as well as metastatic disease. Primary ovarian carcinoma will be more common than metastatic breast cancer in the majority of patients with this history. So though the history can be helpful, it does not firmly establish the diagnosis. So our final diagnosis today is metastatic ductal carcinoma of the breast involving both ovaries in a patient with a prior history and a period of hormone suppression. Thank you very much for joining us today for this discussion. Please subscribe, share your comments below, or send us feedback directly. And we hope to see you again soon for another surgical pathology digital slide sign out and case review.